This is our last session, but it's one of the most important. So we've talked about ways of assessing sickle cell disease, managing sickle cell disease, and now looking towards the future, we want to look at more innovative ways to treat sickle cell disease and also potentially cure sickle cell disease. So with our last session today is on precision medicine in sickle cell disease, integrating genomics, biomarkers, and personalized care. So I'm going to go ahead and introduce our speakers for this session. We have Dr. Kumar, and Dr. Kumar is a transplant hematologist at Princess Margaret Cancer Center and UHN, and a professor of medicine at the University of Toronto. He previously served as head of malignant hematology and held academics and hematology positions at the University of Manitoba and All India Institute of the Medical Center's Sciences in Delhi. Sorry about that. His special interest is in transplantation and sickle cell disease, and he initiated adult sickle cell disease transplants in Toronto. He currently serves as the co-chair of the Hemoglobinopathy Working Group of Cell Therapy Transplant Canada. Our second speaker will be my previous hematologist, and still current hematologist, Dr. Ko, who is the Vice President of Research and Innovation and an adult hematologist at Scarborough Health Network, where he is leading the development of a research institute focused on AI-enabled innovations in population health, clinical research, and technology-centered education. He is also an associate professor at the University of Toronto. Dr. Ko specializes in adults with rare anemias, including thalassemia and sickle cell disease, with research focused on new treatments, improving care and outcomes, and the effects of sickle cell disease on memory, thinking, and pregnancy. We'll start with Dr. Kumar.
So thank you so much for that introduction. These are my disclosures and the objectives of my talk. So I'm going to talk about how genetic and biomarkers in a patient with sickle cell disease determine what kind of treatment we can offer and individualize it so it is most effective and safe. I will focus on the curative or transformative therapies because that's my focus of interest. And I know by now this audience is well aware of the routine care complications in general and especially with the last 2 days meetings. I will try to use non-technical terms because we have a mixed audience, but in the question and answer, please ask me any details. So just to clarify some terminology. So what do we mean by genetic data? Genetic is something we inherit. We cannot really change it unless we edit the gene, for example. So let's say we have sickle cell disease, but at the molecular level, it could be HBSS or SC or S-beta thal, all technical stuff, but that will determine if a particular gene therapy is even possible. We also have blood groups. We all know what is A, B, O, and so on, but there are many other subgroups, and they are very important because sometimes with the same blood group, people are destroying their blood because they need some special genotype blood. And then we have HLA. So HLA is, is something called our body has to recognize foreign and self. Histocompatibility kind of thing. But it is also very important for transplant because if people are completely HLA divergent, you cannot do any transplant. So this we cannot change. Biomarkers are those things which we can measure. They can be physical, like blood pressure, how fit a person is. That's a biomarker. Or it can be lung function, kidney function, or things like imaging. You do an echo, the heart function or the CT scan. Or we have antibodies to blood or, autoimmune disease. So that's a biomarker. Okay, so before we proceed, I thought I'll introduce this article we published in the Canadian Medical Association Journal. And it's meant for the general practitioner. not the hematologist. It is open access. You can access it now. So let me just show you what it says. Let's say there's a patient and they are eligible for a transplant. So the lower part shows the journey. If they have a donor, then collecting cells from the donor is very easy, from bone marrow or peripheral blood. And then you admit the patient and give them chemo radiation so they accept the donor cells. That's called conditioning. And they admit it for about 4 or 5 weeks. And once the cells grow, they are discharged, but they have to be followed up for almost a year to make sure they don't reject and they don't get complications. On top, you have what's called gene therapy. Now, the beauty of gene therapy is you don't need a donor, you need the patient's own cells. But it's not that simple, because they need exchange transfusions, they need many weeks and months of collection, and sometimes that fails. And then these cells are sent to this manufacturing site, and it takes 2-3 months for the manufacturing to take place. So once you get enough cells, they are flown back, and then patient is still admitted, and they get conditioning, which is much more toxic actually than transplant. And I'll come to that later, but once it grows, it's easy because they don't need that much follow-up. So both are good, both have their own plus minuses. So let's first talk of transplant. What is the ideal donor for bone marrow transplant? And that's an HLA-matched sibling. So this is just a cartoon to make it sound simple. So we have a patient, you can see on the right side of your screen, and we inherit our HLA from our parents, one set from father, one from the mother, and that's shown here. So the patient has got this blue and green. Now, if this patient has 4 siblings, statistically, only one of them, the one on the extreme right, will be HLA identical. The others will not be HLA identical. And of course, we don't all have 4 siblings, and then it's only chance. So you may or may not get a donor. Okay. But assuming someone has a matched sibling donor, transplant is the best option. Obviously, transplant is only done if someone has severe disease, not just because if you're fine, then why do it? And the biomarkers will determine if the person is eligible for transplant, and also what kind of protocol we use. Protocol means what kind of chemo, etc. we give. So currently at our center, there are 2 protocols, and I'm talking of the whole world for adults. One is called non-myeloablative, and as the term means, it does not destroy the marrow, so non-myeloablative. The advantage is very safe. Disadvantage is not that effective, so you can reject the donor. The second one is more intense, better growth, but it's called reduced intensity, so it's more intense than the first one. So let me come to the non-myeloablative. This was developed in the US at the NIH, and that's shown on top there, on the right side. There is no chemo at all. What the patients get, the first part, the white one, is an antibody, alemtuzumab. Then they get 1 dose of radiation, shown in yellow, and then they get the cells from the donor. And they also have to continue a drug called sirolimus for at least 1 year or longer to allow the cells to kind of keep increasing. Now, what are the results? If you look at the lower part of the right, that's from 3 centers. They had 122 patients. I'm just summarizing a few facts. The indications are shown there, like vaso-occlusive crisis, acute chest syndrome. Keep in mind that a stroke was an indication in 1/3 of the patients. Keep this in mind because for gene therapy, that's not an indication. Okay, and then what is the outcome? So if you look at overall survival, it is fabulous, 98%. In other words, risk of dying is almost nil. However, 13% rejected their graft. They still survived, but they went back to their sickle cell state. So the cure was only in 87%. So very safe, but not that effective. And on the right side, this is an update, 200 patients, single center, again, similar results, very good disease-free survival, but some graft failures. So that's the downside. So further progress to reduce graft failure and get better engraftment, we have this reduced intensity conditioning which I mentioned, and that is shown in that illustration or cartoon on the right side. You know, there are many colors, squares, just to tell you there are many different drugs to be given, quite complicated. And then they get the cells and then they get more chemo, but it is very effective. And this is a study recently published, 25 patients, all matched siblings. Look at the survival, 100%, 2 years. And disease-free survival, cure, is 96%. Actually, the reason why it's 96, not 100, because one patient had bad graft versus host disease. So it's not event-free, but, you know, very effective. So now if you have a sickle cell disease patient with a matched sibling donor, we have 3 protocols. One is non-myeloablative, the one I showed you, and then we have 2 reduced intensity conditioning ones. The one I showed you that contains a drug called thiotaper, and there's one more where there's no thiotaper, it's a bit more radiation. And depending on the biomarkers, you may choose one or the other. So we can individualize treatment. We don't have only one treatment, okay? So now let me move over. Suppose someone does not have a matched sibling donor, and actually in reality less than 20% have a suitable donor. What about them? There are only 2 options to cure them. One is gene therapy, and second is haplotransplant. So let me first talk about gene therapy, because there's a lot of excitement and obviously awareness. So the good thing is Dr. Kevin Coe will expand on this, so I won't go into great details. Just to mention, in the world there are only 2 approved gene therapies at present, and in Canada there's only one, and that is by Vertex. You know, they are one of the sponsors of this meeting, and their results were published in the New England Journal of Medicine 2 years ago. How the gene therapy works, they edit the gene so there's more fetal hemoglobin produced, which prevents crisis. So details will come later. Now, Health Canada approved it, then it went to the Canadian Drug Agency, and they looked at all the criteria, funding, and so on. And I'm just summarizing a few facts. To be eligible, patients have to be more than 12 years of age. Okay, so slightly older. They have to fulfill the criteria shown there. That means each year they should have at least 2 or more vaso-occlusive crises for 2 years. So if they have mild disease or it's very well controlled, they are not eligible because it's too complex. Why not continue with conservative management? And there should be no willing, fully matched sibling donor. I'm glad we put the willing part, because otherwise they would say you have a donor, even if unfit, you know. Okay. So how does gene therapy work? I'm again showing you this illustration, which was published just this year by the International Society for Gene Therapy and the American Society for Transplant. Again, a good overview. So you have the patient on the left side top of your screen having many months of red cell exchange and collection. The cells come down for manufacturing. Once they are done, they get, again, what I told you, myeloablative conditioning, and that's how it works. So let me go into some details. Most patients with sickle cell disease are on hydroxyurea, and they may be well controlled. But the first step is you stop hydroxyurea. Instead of that, you have to do red cell exchange for at least 2 months before the first collection. And that is not easy, it's a challenge. They then get plerixafor, which is an agent to mobilize their stem cells, and it's not the most efficient agent. And this is given only about 2 hours before the collection, which means early morning at 6 a.m. or 5 a.m. And then collection is done for 3 days in a row. And the amount you need to collect is 20 million CD34 cells per kilo. Now, that is Greek to you and me, but let me explain. In transplant, we need 3 to 4 million only. So now you need about 5 times as many cells. So it's not easy, and very often patients have to come again and again for the collection. And in about 5%, despite 4 or 5 collections, they may not have enough cells. Sorry about that. Okay, so patients also need admission before mobilization. It's just the logistics. You can't come from home at 5, get an injection and complications. So this is one major challenge here. Once the cells come back, you need myeloablative busulfan. That is very much more toxic than what I told you in transplant. And why you need to give this? Because these edited cells, they've been battered, bruised, frozen, etc. They don't have a survival advantage over their own intrinsic sickle cells. So you have to destroy the sickle cells first. But busulfan is quite toxic to the liver, the heart, the lungs, and so on. So the biomarkers determine if someone is even eligible to receive this busulfan. Secondly, during the busulfan, we have to monitor the level. Because if it's too high, it's too bad. If it's too low, it's ineffective. So again, biomarkers in a way. Okay, let me go back to transplant now. So what about haplotransplants? So let's revise this. So this patient got half from the father, half from the mother, each haplotype. In other words, the parents are always haploidentical to a patient. And if they have 4 siblings, 2 out of them, the ones in the middle, will be haploidentical. So it would be fair to say that almost everyone will have a haploidentical donor. Almost, not all. So can we do transplant for them? And some years ago, I would have said nothing doing, but now it is possible. So we got to confirm that they are really, truly haploidentical. And they have no antibodies to the patient does not have antibodies to the donor, otherwise they'll reject. And there are 2 main protocols, which I'll come to. They are both reduced intensity, and we need bone marrow harvesting. So the donor, ideally they should be of the same blood group, and the weight should be kind of similar. So let's say patient is 100 kilos, and the donor is a young sibling who's 50 kilos. You can only collect what is safe for the donor, so you will just not get enough. Okay. So these are some of the latest publications. Again, a bit complicated, but just bear with me. So on top, this is a big trial published, many centers in the US, similar thing, international. So the protocol is exactly what I told you in the matched sibling donor setting, same protocol. It works well. And in adults, the results are very good. If you see, 88% were cured. Overall survival, 95%. The downside, there is something called graft versus host disease, which can affect 5 to 20% depending on the type. The good thing is, at the end of 1 year, most of them were cured of this. And at 2 years, only 1 patient needed to be on medication. So, but patient has to understand that. In the lower part, this is from Johns Hopkins. Again, very good results with a slight change in the protocol. They don't give a drug called thiotaper, they increase the radiation. So now, at our center and most centers, you've got 2 options for haplotransplant, and that we can determine based on the biomarkers. Obviously, there are challenges. Whom do you select? What treatment do you offer? And which exact protocol do you give? To help address this, the Cell Therapy Transplant Canada, that's the Transplants Organization of Canada, along with the non-transplant hematologists, that's CanHeme, came up with recommendations. And I know this sounds complicated, so just bear with me. So on the extreme left of your screen, age less than 12 years. If someone is less than 12 years at present, they are not eligible for gene therapy because that's the way it's funded and trial has been done. If they don't have a matched sibling donor, they can certainly undergo transplant from other donors, but only in the context of a clinical trial. And I'll explain the reason because there are more complications. Now, if they have a matched sibling donor, and this is irrespective of age, we said less than 12, 12 to 17, more than 18, then a transplant is the best option. And in this study, we said non-myeloablative is better, but we just changed our protocol. Reduced intensity may be better for reasons I told you, less rejection. So now what about those who don't have a matched sibling donor or they are not willing? Then we have only two options, gene therapy or haplotransplant. For gene therapy, factors against, if they are unfit for high-dose busulfan, obviously they are not eligible. Secondly, if they have a history of stroke, because in the clinical trial they excluded people with strokes. Thirdly, if they have some molecular level hemoglobin SC disease, then the edit won't work. And finally, if there's difficulty doing exchange transfusions, they need a lot of exchange transfusions. If they're having reactions, they can't get safe blood, you can't collect cells. What about haplo? So the main factor against is donor-specific antibodies. Secondly, in children it doesn't work. At least 25% reject. So unless we change the protocol, in children we are not recommending haplotransplant. And so I think those are the two main ones, and patients have to be willing for the risk of GVHD. So if I summarize, we have got genetic assessment, and I mentioned the factors, genetics of the disease, blood group, HLA. We have biomarkers, which will determine severity of disease, eligibility to undergo treatment, organ functions. And then we explain this to the patient, because ultimately the patient has to choose. So patients have their own values and choices. And then as a team, we decide, A, do we do transplant? B, gene therapy? And often patients say, no, I'm happy doing what I'm doing, conservative management. Or I'd rather wait, maybe gene therapy will improve, or transplant will improve. And that's how we individualize treatment for a particular patient. With that, thank you for your attention.
We'll hold questions until after both presentations.
Good afternoon, everybody. I'm very honored to be here today as a keynote speaker at the SCAGO Sickle Cell Summit. Today, first of all, who likes science fiction? Hands up. Okay, perfect. Great audience. The reason is because I'll be talking about science fiction today, especially the latter part of my talk, okay? So the second part of the talk, so watch out for that. So I'm going to start from reality and I'm going to move on. Is it loaded? Loading, I think. Loading. Okay, perfect. I mean, first of all, Dr. Kumar, and you've heard from yesterday about the journey of someone going through gene therapy. When you first hear about gene therapy, of course, this is pretty exciting, right? You hear about all the snaz, all the jazz, all the news. And then, of course, there's these asterisks and fine prints. And really, yesterday and today, even up to what Dr. Kumar has been talking about, those asterisks and fine prints. And so then the question becomes is, how do we overcome those asterisks and fine prints? Because ultimately, what we want to do, right, is to make gene therapy accessible to everybody, not just something bespoke to people. Oh, good. Well, I was trying to delay you there. These are my conflict of interest disclosures. So we talked about this. You all know about this, right? CRISPR-Cas9. CRISPR is the guided RNA, right, that leads the Cas9, which is endonuclease, which is a cutter, essentially is a molecular cutter. It cuts DNA into the target. And what's the target here is what we call BCL11A. Because if we can abolish BCL11A, right, just cut it and make it inactive, then we can make a lot of fetal globin. Right? And that's what we want, because you see, even babies with sickle cell disease don't have any problems with sickle cell because of the fetal hemoglobin that they make. So we're here to make the stem cells young again. Okay? I mean, who wouldn't want that? It's like Rogaine for the stem cells. And we know that it works, right? 97% of people, no pain crises for at least 12 months, if not more. You can see that many of these patients actually were followed for longer than that. Everybody did not have to go to hospital. I mean, who wouldn't want that? And you can see each of these blue diamonds represents either a pain crisis or hospitalization. And now you have people completely wiped clean, right? This is what we see up front, minus the asterisks. Now, let me show you some of the asterisks. We talked about these asterisks already. Dr. Kumar talked about it. Yesterday, we talked about it as well. It takes more than 6 months for this journey, right? A lot of times even longer because of the vigorous screening that we have to go through, all the biomarkers that Dr. Kumar talks about, all those indicators whether you're fit for gene therapy or maybe for something else. You have to go through all of that. Not only that, what we have to do is to move your stem cells, right? We have to move your stem cells from the bone marrow into the circulation so we can collect it with a big machine that looks like a dialysis machine, frankly. And then afterwards, we're going to change your cells in many different ways, right? And then afterwards, we're going to give it back to you. But before we give it back to you, we have to clear house. We have to clear out the existing stem cells. That's what Dr. Kumar talked about, right? That's what he talked about with the chemotherapy, with the busulfan and all those things. Not only that, the collection itself is very difficult. We know that collecting stem cells in people with sickle cell disease is difficult for a variety of reasons, and I'll show you. More importantly is that we need to collect at least, as Dr. Kumar said, 20 million stem cells per kilo. Now imagine if you're 60 kilos, you're going to multiply that number up, right? This is not just 20 million. It's that 20 million multiplied by 60, which is what, I don't know, 12 billion? Yeah, 1.2 billion. Thank you. Thanks, Delaney, who can do math better than me. Not only that, with busulfan, right, fertility preservation, you have to stay in hospital for more than a month, right? Because during that period of time, you're prone to bleeding, you have anemia, you're prone to infection, you have to wait for your cells to regrow. It's like the lawn, right? This is not astroturf, you can just it doesn't grow right away. You gotta give it time for it to grow. And then, of course, afterwards, you have to see the doctor. It's not like you're scot-free. You have to see the doctor every year, come back. You want to make sure that, God forbid, if you develop any sort of, small but real possibility of developing cancer afterwards. So not only that, we have to remember the financial toxicity, right? 2.1 million, well, even if, say, we get the discount that we want, or 39% as recommended by the Canadian Drug Agency, you're still dealing with, the price of a house plus. More in Toronto, exactly. I should say in Toronto, like if you go to, I don't know, Dildo in Newfoundland, it can probably get 2 or 3 houses. Now, as I said before, right, the age and the health conditions really affect the number of stem cells you can get. You can see on the left-hand side here is a graph, right? The number of final stem cells that you get is really determined by, how many stem cells you initially can get. Now, I'm going to interchange the word stem cells or CD34 positive cells, okay? So forgive me for anyone who is like Dr. Kumar. I'm gravely offending here because CD34 positive stem cells isn't exactly stem cells, okay? Stem cell is a functional phenotype. No one exactly knows what stem cell. If anyone does, please put your hand up because we're going to nominate you for a Nobel Prize. But what we can say, though, is that it's like bits and bytes, okay? If we call it bits and bytes, you know how there's always that little bits and bytes where it's like really, really salty? Okay? The really, really salty one is the stem cell, the hematopoietic stem cell. But what we're grabbing here is all the bits and bytes, okay? So all the the CD34 positive cells, as we call it, contains stem cells in there. And then some are more committed than others. So it's kind of like bits and bytes and that really salty one in there. But anyways, going back to this, though, you can see here that people with different conditions and different requirements, right, during their life with their sickle cell, with their health conditions, really affect the number of stem cells that we can collect out of them. And of course, age is a huge factor, right? It's a limiting factor. You can see how the total number of stem cells that we can collect just sort of nosedive to close to very low beyond age 30 there. Not only that, remember we're using, busulfan, and in this case with busulfan you get, your side effects, and you can see that although majority of side effects are contained within the first 3 months, all these are pretty much all from busulfan. So, what can we do? Obviously, we want to, be able to get the stem cells out quicker. We want to be able to get more stem cells out. We want to be able to be more efficient at changing these stem cells. And then last but not least is somehow we want to put these stem cells back into you in a safer manner. Now, last but not least is, what if we can actually take the delivery vehicle, right, that gene editing directly to you by, say, giving you like a vaccine, right? That would be the holy grail. This is what I'm talking about when it comes to science fiction, because majority of the data I'm going to show you are found in either mice or non-human primates. In this case, mostly they use rhesus macaques, and a couple of human studies. So you'll see here we're very good at curing sickle cell mice, but not so much humans yet. But hopefully this will give you a glimpse in terms of what we may be able to do in the future. So first of all, let's step back, right? Let's talk about the collection. Can we improve the collection process? As you all know, traditionally, the way we move the stem cells out from the bone marrow into the circulation so we can start collecting it is using two medicines called GCSF and plerixafor. Dr. Kumar talked about plerixafor. We can't use GCSF in people with sickle cell disease because it causes more pain crises and a lot of complications. So because of that, we like to avoid GCSF, which means that it makes it even more difficult to get stem cells out of people with sickle cell disease, as illustrated on this. And what does plerixafor and GCSF do? Well, they're kind of like cutting the mooring lines, right? You can imagine, let's say you imagine you have a yard, okay? Not to say that you have, maybe you do, maybe you don't, but let's say you do. Obviously, you want to moor your yard safely, right? And so you can imagine this to be like the bone marrow niche, and these are the individual stem cells, the yards, okay? Now, you could come along and someone cuts the bow line. That's exactly what these medicines do, the GCSF and plerixafor. They're here to cut the bow line so that they can steal your yard. And that's exactly what we're doing with stem cells. We're going to cut the bow line and we're going to steal the stem cells so we can start changing it outside their body. But because we can't do that, is there other ways in which we can do this? Well, there's now a medication, it's been approved since 2023 called mictazephodide, and it's a selective CXCR4 inhibitor. So basically, it cuts the moorer lines. Okay, this is one of those new medicines. Now, initially, it's approved for moving stem cells for people with multiple myeloma, but now it's been co-opted and tried in people with sickle cell disease. Now, why is this attractive? It's because this medicine compared to plerixafor has higher affinity, has longer duration of action, plus also we're moving out more primitive stem cells. So we're enriching for those really salty bits and bytes here. And Group et al. Has shown that in 15 people with sickle cell disease who've previously failed to mobilize plerixafor, they are now able to move stem cells out of these people. 73%, 11 out of these 15 people, they're now actually able to move the stem cells out, even though it didn't work with the plerixafor. So, one step closer to being able to more efficiently getting the stem cell out. Another group has tried a combination of this drug with natalizumab. Now, natalizumab itself is actually a very weak stem cell mobilizer, but what people have found is that when you combine it with mictazephodide, is that you can actually, they work synergistically, being able to move the stem cells out even more efficiently, 3.2 times more than, say, with plerixafor alone. And you can see here, even with just one harvest here, you're actually getting very close to that magic number of 20 million. last but not least is, again, this work is currently being done in non-human primates right now. The top graph here illustrates the traditional timeline in which we're moving the stem cells. It takes, a total of 7 days. But what they're saying here is that you can actually do this within a day. Okay, and this is using a CXCR2 agonist called the MGTA 145 growth beta T, and they're able to now move not just shorter timeline, but also move more primitive stem cells out into circulation. Again, you're enriching for those really, really salty bits and bytes, which I just love. And the efficiency is actually very similar to using GCSF, which is what we can't use in people with sickle cell disease. So now, moving on then, now that we have found new ways of moving out the stem cells, well, what about the conditioning regimens, right? Remember, we need to find alternatives to busulfan because of all those asterisks and small prints that we talked about previously. Well, one way is to create a reduced intensity conditioning regimen using malphalan, and you can see here that with this reduced intensity conditioning regimen, we're able to the team is able to reduce the time that it takes for the neutrophils to recover, the time that it takes for the platelets to recover, and also the hospitalization time as well. And you can see on the bottom right here, right-hand graph here, you can see here that although the fetal globin is not as high as we would like to see it, but these are more primitive stem cells, so it's theorized that you can have a more lasting effect if say, someone was to undergo this gene therapy. Now, another breakthrough that people have found recently is called CD117. So before I go into sort of funky ways in which you can play around with CD117, let's explain what it is. CD117 is a marker on the stem cell, okay? And with this marker, what it does is that it's essential for self-renewal, for the stem cell self-renewal, for survival, for staying inside the bone marrow niche, okay? And if you were to block CD117, it allows the bone marrow niche to vacate and all the stem cells without any sort of DNA damage. So essentially, you now have created a space for your gene-edited cells to come back in and take over the bone marrow. And so not only that, by targeting CD117, you can spare the mature immune cells, which means that you're less prone to infections afterwards, after getting it. Now, the problem with blocking CD117, though, is that previously it does have a side effect of triggering what we call mast cell degranulation, which essentially the symptoms of which is anaphylactic shock. So obviously, you don't want to get a medication that can cause anaphylactic shock. But most recently, though, there has been new changes to the antibody such that it doesn't cause the anaphylactic shock anymore. And so not only that, you can actually hook up the CD117, the antibody, with a drug conjugate. And what that does is that allows you to actually deliver the drug or deliver whatever vehicle that you want to deliver, to the stem cells. Because remember, CD117 is found exclusively in stem cells, so now you're well, not exclusively, but mostly found in stem cells, but you're homing into the stem cells now. You can sort of use it as like a delivery vehicle. You can even hook it up with T-cell engagers as well, with what we call bispecific antibodies. So now this really has sort of opened up sort of an avenue of us tackling stem cells, because at the end of the day, right, when traditionally we use chemotherapy to sort of clear the bone marrow, it's non-specific. You're sort of just like carpet bombing the entire bone marrow. But now, instead of doing that, we can actually just target the stem cells and wipe out the stem cells selectively. Not only that, not only can you sort of wipe out the stem cells selectively, What you don't want, though, is that you don't want your engineered stem cells. Remember, we're doing gene editing, right? You don't want your gene-edited stem cells to be wiped out as well. So then the question is, how do you wipe out your previous stem cells but not wipe out the stem cells that you have engineered? Because all of them supposedly have CD117. So what you do is that you combine that antibody with what we call a single base editor, which means that you can actually cloak the stem cells that you have modified. Okay, so by hacking the CD117 on your modified stem cells, now you've cloaked it so the antibody doesn't attack it anymore. So you can just attack the ones that haven't been edited and spare the ones that have been edited. Now, not only that, people have actually come up with ways to hack not just the CD117, but also to hack, say, the BCL11A. Remember the ones that we want to silence so that we can make a lot of fetal hemoglobin? So you can do that in one go. So now you have the antibody that takes off all the stem cells that has not been edited off the bone marrow, plus it allows the survival of the stem cells that you want, the ones that have been edited, because now you've cloaked it. This is the basis of a trial called BEAM 103. Currently is in the preclinical stage. But in macaques, we can, well, if macaques ever have sickle cell, they're very lucky because now they can get F cell levels that are up to 98% and gamma globin levels up to 88%. Okay, essentially, effectively curing them with very minimal side effects on these monkeys. And then Kesarati as well, et al. Has actually, hooked it up with a BCL11A edit. The one that from BEAM is a little interesting as well, and it's very specific for sickle cell because what they do is that, as you know, that the change in the sickle cell is the 6 codon, right? It's the 6 amino acid on that chain of hemoglobin amino acid chain. And with this mutation called a Makassar, it can actually change that particular mutation, change it from a sickle mutation to a mutation that actually makes it more beneficial. So now, after all of that now is, well, where's my holy grail? Where's that jab that's going to cure my sickle cell? This is where it really, really is completely science fiction. So what we call in vivo gene therapy, okay? So as you can see on the top here is the illustration on the top, right there, top figure is traditionally what we do, right? We have to admit you to hospital, you're gonna need to not be a job for a while, or if you're at your school, you're gonna take time off, at least 6 months, and this and that, you gotta have your stem cells mobilized, yada, yada, yada. May or may not work because it could take up to 6 times or even more to mobilize your stem cells. Well, what if we can do all that and just one go and give you a jab? Well, there's actually 2 ways in which people are developing that right now. One way is what we call lipid nanoparticle based. And what this lipid nanoparticle is essentially is just lipid, fat, that's what it is, but you can change fat into a sort of nice little round blob of oil that can contain the RNA that you want to use to modify the stem cells, okay? So not only that, in order for these little blobs of oil to target specifically stem cells, you can even hook it up with an antibody that homes directly to the stem cells, so kind of something like a CD117 antibody that we have talked about previously. So that's one method. The other method is called helper-dependent adenovirus-based. Okay, so let's break that down. Adenovirus, most of you know, causes a cold, right? How does it work in this case? Well, you first take an adenovirus, the DNA of it, you gut it completely, okay? So you basically clear house. It's like buying one of those old homes and you're gutting it and you sort of, those historical homes that you guys gut, right? So you can do that. So you gut that historical home, you put in the gene editing that you want, the gene editing machinery that you want in there. But now, how do you build that home up again? Well, you actually don't rely on the virus because what you don't want is you don't want the virus to go in there and start replicating and giving you a real bad code, okay, that can kill you. So you don't want that. So instead, you have these helper viruses that will actually rebuild the home of the virus that, that will carry this genetic engineering piece, this gene editing machinery, but it doesn't itself lead to, making more of itself. So now you can safely deliver this to your stem cells without having it causing a real bad code in you. So what are some of the examples? There's at least 2 out there. One is by Farouk, where they have used a liposomal vector, similar to what we've shown, but instead you're coupling the CRISPR-Cas9, very simple, same CRISPR-Cas9 that we've been talking about with exa-cel, but now you're coupling it with a CD34 targeting peptide. So CD34, remember those cells, stem cells that we talked about, so you can actually hook it up together. It's been working pretty well in mice so far, so mice are lucky. We're not so lucky yet. Gupta et al. From the Etitas group, they use the lipid nanoparticle way, right, where they hook it up with, again, CRISPR-Cas12a, very similar to the CRISPR-Cas9 method that targets the promoters of the fetal globin so it can make more fetal hemoglobin. Plus they hook it up with some sort of way in which they can target the stem cells. We don't exactly know what this is proprietary. They have done this in non-human primates. It looks pretty good. So we look forward to the next chapter of this, science fiction story. So we talked about the current challenges, right, for the past 2 days. And what I've shown here today is that there is non-GCSF alternatives that we can possibly use that can increase the yield and decrease the collection cycles that we need. There is ways to do the conditioning without busulfan using an antibody-based method. But last but not least is that, in vivo therapy is possible. It's just a matter of time, in my opinion, till it gets to us. So with that, I draw it to a close and I welcome any questions. Thank you very much.
Wonderful. Wonderful. Thank you so much for those 2 excellent presentations. Do we have any questions? Any questions?
So great talks. And I think you said it really well that the in vivo gene editing has just the potential to completely, we talked about reimagining sickle cell disease on day 1. This is really reimagining what's possible with sickle cell disease, and it's really cool to see you guys presenting all of that in such a really great way. Question for you all. One of the things is about feasibility and how do we get governments, payers to reimburse for this thing, for these types of therapies. And one of the barriers is the ability to be able to have early predictors of long-term, durable improvement. Based on what you guys have seen, are there indicators that give you guys confidence in early indicators of long-term durability with these therapies? And if so, do you have any thoughts about what they might be?
It's a very good question, right? In terms of long-term indicators of success, I think, in my opinion, has to do with where the person is, the sort of the whole body constitution of the person. Is that person iron overloaded from the transfusion? Have they had previous liver fibrosis, or have they had previous scarring in the heart? How much damage, unfortunately, has already accrued from having sickle cell disease over the years? I think that's the sort of major predictor that I can see right now in terms of long-term success for our patients. And this also speaks to the fact that a lot of the, I know that Vertex is doing it. They're aiming for people under 12, right? Is to intervene before the damages starts to accumulate.
Yeah, so it's a very good question. I can just say the best person to tell you is the patient, not me. We have a patient rep in our CTTC who underwent a transplant, and he tells everyone he's never been able to run, exercise, and now he's doing all that. So the right patient at the right time, they do very well, and there's follow-up. Like there are more than 1,000 transplants done in children in sickle cell disease. Problem is, as you do it in older people, what damage has already occurred won't reverse, but further damage will not happen. The other way I can address it, we have a very good nurse. He came from Saudi Arabia, and he just got a PhD, by the way. What he did, he compared those patients who underwent transplant and compared with those who had a donor but could not undergo transplant because for some reason. And he compared their quality of life from the patient's angle. And there was a very clear difference, improvement in the quality of life. I'm not talking of survival, because with modern technology, even someone with severe disease will survive, hopefully, if we keep doing the right treatment, but they will still have pain, they'll have complications. So it works. But I can't say in every case, because there may be some complications. But as we improve and make our processes safer, it should work and should improve things. But the right time, that's important.
Thank you. Dana Ramsey, I'm a parent and caregiver. Dr. Cohen, I know you very well through SHN. This question is to both of you. If you were having this conversation 5 years from now, what would you hope has fundamentally changed for people living with sickle cell disease? And what role does each of us have to play in making the future a reality? Thank you.
Okay, so 5 years from now, if I understand, what will I say? So one thing I'll tell you very clearly, because I don't like to say what I feel. I bring the patients in. We'll have much more data. So right now, our center has done only 15 transplants, 16th is undergoing. We plan to do at least 25 a year and bring their voices, and that will change and convince people. Even now when a patient comes and I tell them A, B, C, the way Dr. Ko explained and I explain, and they are kind of confused. They say, would you like to talk to a patient? And they say, yeah, that'll be great. And I can tell you every patient is willing to talk. And then you talk to each other, and so that's number one. Secondly, technology is changing. As Dr. Ko said, what we are having today, we didn't have 10 years ago. By the way, before 2019, our center did not do a single transplant for sickle cell disease, even though we do 200 transplants a year. And then we started because then protocols became available, and we are increasing. We haven't done a single gene therapy yet because it's not funded. That will increase. But in future, I honestly think that in vivo should be possible. I'm just worried about the cost, because whoever does it, they'll raise the cost sky high. But if you have in vivo, then it will be applicable to people in those parts of the world, in Africa, in the Middle East, in Asia, who can't get the kind of treatment we are giving here. But hopefully science will make it possible, and that will be the best thing. Then you can give it at a community center, like a package. This science fiction, but unless you dream, nothing will happen. So.
Yeah, Dina, thank you. Thank you for the question. I think we're making progress every day, and I do see it. And in 5 years, we may not have in vivo gene therapy yet, but my hope is that it will be in clinical trial at least. At least we can offer this to people in Canada in a clinical trial setting. I'm also hoping that in 5 years we'll find better ways and newer ways of getting the stem cells out so that it's less burdensome for people. I think, to me right now, is that the editing technology itself, I think is already very good in terms of efficacy. I think what we need to do in the next 5 years is to make things more safer and more accessible. And the only way we can make things that are safer and more accessible is with some of these newer techniques, so that it's not as burdensome in terms of, and I don't mean just cost, right? I mean it's the time that people need to take away, the family need to take time away in order to care for the loved ones, right? To be in a hospital day in, day out, getting the stem cells out, going through the conditioning regimen, going through the screening, et cetera, going through all that, right? Just to get it done. We need to find ways of simplifying that process, and I place good hopes on that. And I hate to say it, this is where we need competition, right? The more people that are invested in this, I think the more options we'll see available.
Hi, this is a question mostly for Dr. Kumar, but I want to thank you for speaking. Dr. Kuo, your information was so palatable, so digestible, so I want to thank you for making this really available to us. So I was looking at one of Dr. Kumar's graphs, and after 12, it said that gene therapy was unavailable for patients with hemoglobin SC. And so what's the alternative for them for gene therapy?
So that's an excellent question. Firstly, if someone has severe disease, and that's defined, you get complications, they have the option of transplant anyway. So the difference between transplant and gene therapy makes a change in the gene, like in this case, increasing fetal hemoglobin. What transplant does, it's like a hammer. It replaces the whole blood from the healthy donor. So it's a bit crude, but it's much more effective in a way. And if you can tolerate the initial toxicity or being admitted and the potential complications, which are increasingly less with modern technology, that is your option, to my mind.
For me, it's more a comment, I would say, more than a question. And I thank you for this presentation. Why am I saying it? I thought I knew, not everything, but I knew what it was about the gene therapy and the new therapies. Like I think it's Dr. Fasipe was saying, when those news came out, in New York, there's someone that has been cured. The number of people that tagged me that were like, your son has a solution, why are you not taking it? Even for me, I was like, it's expensive, but I thought that was the only barrier. I'm not saying that the other things are barriers, but understanding that it's not just a straight, like you start and you get it, really, like it was an eye-opener for me. So I just wanted to thank you for that.
Dr. Kuo, I didn't know if you want to respond to the transfusion versus gene therapy question after age 12, or you're okay. The question from the gentleman there about transplant, or not transplant, but transplant after 12?
Oh yeah, so one more thing, maybe I didn't answer that. So the current gene therapy which is approved, for that SC is not, but there are so many different kinds which Dr. Ko mentioned. So for them, gene therapy may be an option. Okay, I'm just saying because depending on the technique, it may not affect a particular genotype of sickle cell disease, but another technique may be effective.
My only question was just around My only question was just around stem cell transplant, the age. I'm just trying to appreciate the ages of when it's the best to be able to qualify for each of those types of treatments.
So the younger, the better. But the younger the age, the better people tolerate it. But we did one person who was 48 years of age. He sailed through it. He's now more than 52. So, and I'll be honest, for the other leukemia and cancer, I've done transplant for 76 years of age. But for sickle cell, we want to be careful. We don't want to do something which may be harmful. So we are going slow and steady. So we are taking younger people, but the younger the better. And as Dr. Ko said, if you're 10 years or 12, it's even better because then you don't have any organ damage. But at the moment, we are ideally saying less than 50 years and fit.
Yeah, Karen. I also want to add where we currently struggle with is how young do we do the transplant? Because you can harvest sperm and egg for fertility preservation up to a certain age, but below a certain age it becomes extremely difficult. And we know that. Well, first of all, there's that entire ethics piece, right, about parents deciding for the children in terms of, but then if you're not alive, then how can you procreate, etc. It's just, I'm not even going to get into that, but that's one aspect to think about. But the other aspect is, from a technical perspective, preserving oocytes or eggs is extremely difficult in someone who is prepubertal. So you need to do what we call oocyte en bloc freezing. So you literally it's very invasive. You take out the entire block of ovarian tissue and you freeze it. And even with that cryogenic freezing, half the time it wouldn't work, after you've reimplanted it. So there's a lot of technical challenges. And this is why I'm hoping that, with better antibody-based conditioning regimen, we can avoid having to do all of that.
Yeah, I just wanted to actually make one comment about that, because I don't know if this group knows, but the FDA did approve this Casgevy for individuals down to 2 years of age. So in the U.S., it has been approved by the FDA for individuals younger than 12, but just wanted to say that.
You're right. So that's the new thing. Health Canada has yet to approve. This will change because the approval depends on the clinical trial. So in the initial trial, they were older, so they approved those people. Now you do another trial with younger people and you show it's safe, then it's approved. So things keep changing. And the antibody-based, absolutely. We want not only for sickle cell for other transplant, but it has to be approved, funded, safe. It will happen. I just want it to happen earlier.
Thank you so much. I had a question about the donor. What would the age requirement be for a donor for stem cell? Yeah.
So actually, they have ideally adults, but young children. The age is not a bar. Can't be 4 years old. They have to be weight-wise okay to donate cells. So in general, young people means younger than 50 years of age, and 14, 15 and above, because that's probably the right age. Okay.
Thank you both for the amazing presentations. So just thinking, as a clinician who treats individuals with sickle cell, and I had worked in transplant even before. So one of the challenges, as like you just mentioned, is the fertility issue, especially with myeloablative conditioning in children. So do we have fertility data on these reduced intensity and non-myeloablative regimens in adults? And I'm wondering, I think still in peds, still myeloablative is still more commonly used. How far are we in adopting the reduced intensity and non-myeloablative regimens in children?
Okay, so the non-myeloablative, the one I showed you, the safe one, fertility is often preserved, but you cannot give an exact number. So people have had children, like after transplant have a child. So it's not just resumption of menses or sperm, actual kids. And in one of the reduced intensity, the Hopkins protocol, they recently mentioned how women undergoing transplant had normal menses, normal hormones. The only problem is when we counsel patients, we cannot promise that. Because it's difficult to promise anyway. Even normal person with no problem, how can you say that? So we do say you may lose it. We always advise about fertility preservation. As Dr. Ko said, there are many ways of doing it. In young people, you can preserve tissue. It's quite complex. You have to actually take a biopsy, freeze it, thaw it later, and it may not work. So some of these work, but I think patient has to be prepared that they may not retain fertility. What we can say with the gene therapy, using current busulfan, we always say there will be no fertility, so you have to preserve earlier. Because that is really very high dose, and there may be an exception once in a while, but that's the advice.
And just to add, for the antibody-based regimen, currently they're only being tested in the macaque monkeys, as you know. But good news is that the macaque monkeys are really going wild, and there has been a lot of pregnancies in the lady macaques. So it's looking very promising.
Hi there. My name is Beverly Nduku. I just have a question about, I guess, gene therapy and stem cell. I feel like since gene therapy has come out, there's been a lot of attention in terms of curative measures for sickle cell disease. And I do feel like the suggestion of a stem cell transplant has been more readily available to patients. Like, since the gene therapy has come out. Am I wrong in thinking that? Is there any reasoning behind that? Or, like, of course you would want to cure sickle cell. Like, it's great. It would be great to cure it. But I guess for me, it's kind of like there's always been that thought of the chemo, the radiation, all that going on. Is there a push right now to kind of do more stem cells?
If I may answer. So firstly, to be very practical, gene therapy is not yet funded. So I can't offer it. But when it's funded and I talk to patients, I tell them both options. Believe me, some patients say they don't want gene therapy at the moment because you talk about busulfan, talk about fertility, and then you say, okay, the other one is non-myeloablative, reduced intensity, and some of them say, I would prefer that. So actually both are very good options. We are not pushing to anything, and when gene therapy is there, we will be pushing both, but ultimately the patient has to choose. I don't want to push one against the other. I think both are good options. The individual has to make a decision.
Beverly, that's a very good question. I think it's there's a number of factors why we're seeing more about stem cell transplant. Partly because when we talk about gene therapy, stem cell transplant is the bedrock, is the foundation, right? Like the techniques is exactly the same, except that you're getting your own cells is being changed and manipulated before being sent back to you. The bedrock, like the foundational approach is very similar. So when you talk about one, you can't really talk about the other as well. And so when patients ask me about gene therapy, I have to talk about stem cell transplant with them as well. That's one. Second of all is I can tell you the stem cell transplant moves way faster in terms of improvement in technologies and approaches than, say, traditional drug-based therapy. And the reason is because the approach is more tailored and more bespoke. So if I may speak as an outsider, just reflecting on your community, is that because these are very small bespoke trials, you can actually keep on improving. In fact, a lot of times when you see one trial, there has been like 3 changes to the protocol as a result of seeing things that we tried this method A, looks better, then now we're going to do method A and everybody, plus we're going to add another method B. Just to see if we can improve things. So even in one trial, you see like 2 or 3 changes. So the movement, I feel like it's more rapid than, say, having to wait for a clinical trial to complete, see the readout, then move into the next phase of the clinical trial, then wait for its readout, et cetera, before moving on to the next step. That's just the way I see it.
No, I agree with that. And if I may add, I answered the question about how young a donor. So one correction, I'm talking as an adult transplanter. But for children, let's say there's a child who's 8 years old, the donor can be as young. I've done thalassemia transplant with a donor being 4 years old. Wow. Because the recipient is also young, so they can donate enough. So my apologies, because I was talking like an adult, you know.
One final question. Any final questions? All right, Donnell, close us out.
Great. Thank you so much for that presentation. I do have one question, if I may take the initiative to ask. If you had a patient, theoretically, doing well on hydroxyurea and they're 13 years old, would you advise them to do cellular gene therapy or stem cell transplant?
13 years old, hypothetical, and person is on hydroxyurea. Any complications?
No complications on it.
Nothing, like happy as a clam. Doing well at school? Neurocognitive assessment is good?
Yes.
Yeah, everything is well? I mean, that's just my opinion. I would hold off.
And I'll tell you the actual case. Young man, 20 years old, matched sibling donor, doing very well on hydroxyurea, no pain, no crisis for 3 years in the university. So I said, yes, I can do a transplant, but these are the plus minus. I don't think you need it. What do you feel? He says, no, I don't need it. Because that's very important. You don't transplant just because you have some option like gene therapy or a donor. If your conservative management is working well, no complications, I mean, absolutely, then why do something more?
Wonderful. Thank you so much, everyone, for